En ja, Joost heeft net die page laten zien, heb je gezien, hè?
Was die van
Maar,
mij?
nou, dat was niet van jou, nee.
Ah.
Nee.
Ah, kom.
So, and actually, first he gets the microphone and later you take over. Huh? Okay.
Want je hebt toen 3 foto's gemaakt, hè?
Ja, dat was veel, hè? See, there is a little delay. Maybe Francesca, you can check if it's visible in the lecture room. Yeah, would be nice.
Ja, nou achteraf weet ik drommels goed hoe dat komt.
De fiets, toch?
Fietsen, ja.
Mhm.
Een paaltje stond in de weg en dan bleek een fietsstans achteraan. En dan krijg je een ruk op je schouder.
En toen voelde je hem.
Hè?
Toen voelde je. Hoe lang is het nou geleden?
Dat is al bijna 2 jaar terug. Ik zal mijn vrouw eens even bellen. Mijn vrouw en gsm stak je samen. Ze heeft hem wel bij, maar dan laat ze hem uitstaan. Kijk hoe dat daar gaat, het geld op.
That's okay. Doen we dadelijk met jou. Dubbel tarief, hè? Jongens, ga je eventjes een beetje buiten eten, anders krijg je allemaal kreumeltjes hier. Kom je zo terug, ja?
Op het scherm in 1 keer,
Mhm.
we waren er vorige week mee bezig. Ja.
Lukt wel hoor.
Hè?
Dat lukt.
Als je het eenmaal weet, is het simpel, hè, denk ik.
kom erbij. Welkom. We gaan over een paar minuutjes beginnen. Hey, ben je daar, Steven? Ja, wij gaan over een paar minuutjes beginnen. Hè? Ja, precies. En kan je het zien? Heb je de Fontys vlag? Dat klopt. Oké. Moet ik nog even geluid? Dadelijk. Even geluid. Oké. Oké, prima. Zie ik je zo. We gaan zo beginnen. Jo, ai ai. Zo beter, Bas. Oké. Ja, Bas die zei dat het geluid harder mag vandaag. Oké, nou hoort hij het beter. Veel beter. Dankjewel, Bas. We gaan beginnen. Ik denk dat sommigen nog in de collegezaal zitten. Oké, dan gaan we gewoon beginnen. Hè? Goed mensen, kom er lekker bij. Oké. There is a small delay, so what you see here on the screen is a little bit later than when you hear me talking live, so that's why we put out the sound. Very warm welcome to all of you guys in Estonia. Like the Eurovision Song Contest, we have to give notes now to the lecture of Joost, I guess. But it's nice to be around here. Also, I want to thank a lot Ivo and Marcel, who did a lot in the technical department. They are sitting behind screens, but they really did a lot that this is available. I think we can give a small applause for them. Would be nice. Okay, so we are here now to, you heard the theoretical part that Joost was talking about the background of ultrasound, but also the evidence for it and what part it has in healthcare, especially in musculoskeletal healthcare. But we all work with patients, and of course, they are the most important people around us, and we want to give them the best care. So I think that's very good that maybe we can, in an interaction form, work together. Let me introduce. This is Hank. Hi, Hank.
Hello.
Have a seat. Hank has a little cold, that's why he still has his coat on, I guess, but he will take it off later on. Actually, what we're going to do, I'm going to walk a little bit in front, and we're going to do a small interview with Hank. And his problem that he has is a little bit related to the team that we were talking about before and that you heard Joost talk about. It is a little bit difficult for you to talk English, so no problem. You will be translated. But actually, I met you a long time ago, actually, with some shoulder problems. Could you tell us a little bit about that, Hank?
Ja, dat is nu, denk 2 jaar terug is het begonnen.
Okay.
Met het fietsen.
Mm-hmm.
Met
Yeah.
het fietsen. En toen ben ik met mijn fietstas achter een paaltje blijven hangen.
Okay. He says, should I put it on? Yeah, now it's working. Okay. Doe nog maar een keertje.
2 jaar terug was ik aan het fietsen. Ben ik met mijn fietstas achter een paaltje blijven hangen.
Okay. Actually, he says he was cycling. You know, we Dutch people are famous for cycling, so that's what Hank also did. And he was actually passing by a pole, a stick, and his back was kind of twisted behind this pole or stick.
Ja, en ja, toen kreeg ik een ruk op mijn stuur.
Actually, he says, in my steering wheel there was kind of an abrupt force there.
En het gevolg was dat ik een verschrikkelijke pijn in mijn schouder voelde.
Immediately I felt quite a lot of pain in my shoulder joint.
En toen heb ik 3 dagen gewacht. Het werd iets of wat minder.
He says, I waited for 3 days, so I thought maybe it will go away by itself. And actually it decreased a little.
En het werd ook iets minder. En toen, een week of 3 naderhand, begon het helemaal opnieuw.
He says, but actually, so I thought everything will be fine. But then, let's say, 3 weeks later, all of a sudden it started again, the pain.
Toen ben ik maar meteen naar de fysiotherapeut gelopen, therapeute. En die concludeerde nogal snel wat er aan de hand was.
Yeah, so actually he went to see his physiotherapist around the corner, and she made a conclusion. We are not going to tell you what she said, because we are trying to find it out ourselves, huh?
Ja.
Yeah.
Ja.
But how did it go? How did your therapy go?
Therapie dat heeft geduurd bijna 1,5 jaar.
So it took about 1.5 years, he says, the whole part of therapy.
En het is nog niet helemaal over.
And still, I feel sometimes some complaints. It's better, but still some complaints are there.
Het is een stuk beter als natuurlijk eerst, maar
he says way better than in the beginning, but it's not really, let's say, ending. Okay, that's a little bit your story about your shoulder. Huh? Okay, now we have some students sitting around here. We have some students and maybe teachers or whatever also on the other side. If you hear the story of Hank, what kind of questions would you like to ask added to his story? Maybe in Dutch. We also have a Estonian, so maybe I can introduce you, Chrislyn. Come forward. So maybe you can say hi in Estonian language. So Chrislyn is also here, and actually she can guide some questions from you guys. We have a WhatsApp open, so maybe now it's time to interact. Okay, wat denken jullie ervoor? So what do you guys think? What could it be in hypothesis? You heard the story, or do you want more information? Now, come on. Try it. They're a little bit afraid here in the Netherlands. What about Estonia? Okay, that's a good question. Here is a question. Which movements are still painful for you, Hank? Dus waar voel je pijn met name?
Waar ik pijn?
Met welke beweging?
Mijn arm omhoog doen.
He says, lifting my arm. Can you show us a little bit? Okay, good. Yeah. Later on we will assess a little bit more than this, but that's what he shows. Okay? Good. Are there any questions coming in from Estonia? Can you check? No questions from Estonia. The strength. Okay, we will assess that later. Yeah. Is it possible to lie on the arm? Can you lie on the arm, or do you like to sleep on the other side?
Gaat wel, maar uren achter elkaar.
He says it is possible, but I cannot do it for hours. Then I turn to the other side. All right? Meer vragen, jongens, wat jullie nog willen. More questions. Okay. So actually, he's asking to your everyday life. Are you limited because of this? Is er iets wat je niet kan doen door die klacht? Kan je alles doen wat je wil?
Alleen iets moeilijker.
He says, actually, I can do everything that I want to do in my daily life, but it's more difficult than before. Check out. Maybe there are some questions there. Yeah, actually, that's the trick, huh? We have to find it out ourselves. The initial diagnosis was the question. Yeah, we're not going to say that, so you have to use a little bit your idea. We don't make it too easy. Okay? But maybe we can switch to hypotheses. So actually, if we think about a problem, then we always think about early hypotheses. You heard a little bit the story of Hank. What kind of diagnostics or what kind of problems rise up? What do you think, guys? What could it be?
Limited range of motion.
So a limited range of motion, but the limited range of motion can be caused by different things. A limited range of motion is more a symptom of something. What can be a reason for a limited range of motion? So we talk here about subacromial impingement, maybe. Do you guys agree? Estonia as well? Could be, huh? Maybe a slap lesion. Yeah, could be. Anything else, guys? Because this is for for our students. This is the shoulder week. Huh? They're really busy with the shoulder the whole week. Okay, guys, come on. What kind of more hypotheses do you guys have besides a slap lesion and a subacromial impingement? Instability. It's the theme of the week, of course. Huh? Which part of the shoulder is really prone to instability? Which one? Because yeah, so actually you're talking about the glenohumeral joint, and especially the anterior part, a little bit inferior part, is kind of prone to okay. Are there any questions from Estonia, or maybe hypotheses? So maybe, could it be a supraspinatus tear? What do we think? Is that possible? There was a trauma. Could it be a tear of the supraspinatus? They are doubting a little bit here, huh? They don't know. Okay, good. But we still keep it maybe in mind, all right? Okay, guys. Why is it so important to first hear the history of your patient? What do you think? Because sometimes if they know you know ultrasound, sometimes they come to you and they say, oh, I have a problem in my shoulder, can you scan it, please? And actually, I don't like it, because I want to hear the whole story of the patient. Can you imagine why that is? Why is it so important that we hear the story and that we also do our clinical examination first? Yeah. So actually, sometimes you find with ultrasound something, but it's not correlated with the complaints of the patient. So some people have problems in their shoulder when imaging, but actually you see there is no correlation with the complaints that they have. Or maybe they don't have any complaints at all, if you would assess, let's say, a shoulder without complaints. Good. Now, because of time, let's continue a little bit. What kind of assessment would you guys like to do? A clinical assessment. Is it maybe an idea to check his range of motion? Would be, yeah? To check the range of motion of Hank's shoulder would be a good thing. Anything else? I heard strength. Anything else that you want to know? Passive range of motion, maybe. All right, good. Active, passive range of motion. And maybe we do some specific testing. Maybe we can also think about what kind of tests that you want to do. Estonia has some ideas still, otherwise we will ask. Palpation, of course, on pain spots. All right, we can do that. no problem. If they pop up something else, you will tell me, yeah, no problem. Hank, if you don't mind, maybe you can take out your shirt and also your t-shirt. Okay, go ahead. So Hank is capsular mobility, range of motion. Yeah, all right, okay. I don't see how we have it on screen. Marcia, are we still visible? When Hank is standing like this, maybe you turn. Yeah, okay, good. Hank, you told us that you have a problem a little bit with lifting your arm forwards and sideways. So maybe you can first show it with your uninjured shoulder, dus de kant waar je geen klachten hebt. En dan laat je dan de andere kant even zien. Ja, dus gewoon de zijdelings en voor. Dus ja, doe maar helemaal omhoog. Helemaal omhoog. Oké, this is the uninjured side. Okay, so now we have an idea about his range of motion. Can you show it now on the other side, please? Yeah, and now forward. Okay. Can you do it one more time? But now you do it both sides at the same time, okay? Yeah. And you tell us if you feel something, yeah?
Nou voel ik een knak.
He says, actually, I feel a click now.
Nou weer.
Now he feels it.
Nou ook.
Now he also feels it. And when you're up, it's gone.
Ja.
So actually, in this range,
Deze hoogte.
yeah, so here and there,
Yeah.
you feel a click,
Yeah.
all right? Okay. So how does this help us in our clinical reasoning program? Can we still go for hypotheses that we have? Yeah? So what kind of hypothesis is there? Did you also check a little bit the way he is lifting his shoulder? Do you see a difference between left and right? Can you do it again? Ja, allebei tegelijk. Okay, and now forward again. Okay, good. Can I ask you, Hank, to turn with your face there? And that you also do it sideways and upwards. Ja, dus zijdelings en omhoog. All right, and upwards. Do we see a difference? Or is it difficult to see for you guys? Okay, once again. Zo, nog een keertje. Dus langzaam, langzaam Henk, niet te snel. En naar voren. En terug. What do we see, guys? What do you see? Come on. Do you see something or is it normal? Actually, klopt dat ook, Henk? Kost het meer moeite?
Kost iets meer moeite, ja.
Yeah, he says it's actually what we saw, and also what Hank is telling us is that he says it is more difficult for me to do it. All right? Kom maar, draai maar even, Hank. Okay, Estonia, do we have some coverage? The position of the scapula, very good. What kind of thing did they see? Did they see kind of a scapula alata or Kepler sign or something like that? Hoe laat is het, denk ik? Kijken. Oh, wat tijd. Jongens, geef me even een signaaltje als het half is, oké? Even een signaaltje. Ja? Okay, Estonia, something? Yeah? All right, okay. Good. Now, what I'm going to do now, you asked me to assess a little bit some problems, some range of motion. So maybe it's the best to do that while sitting. But I put you a little bit forward, Hank, if you want. Yeah. So actually, we gaan met een hele krukje naar voren toe. Ja, ja, zo ja. Zo is prima. Okay. So we saw some active range of motion. This is the healthy side. I can go to the end. I can even go a little bit further. Dat gaat allemaal goed, hè? Yeah, so I can also Do it here. He says, actually, I don't feel as comfortable as 30 years ago, but this goes quite far. In my opinion, the only thing I can say to you, and that's related to the palpation of Estonia, is that when I do that and I put my hand here, I feel really some clicking sensation. Some clicking, really. Somebody wants to feel it? Come on. You can feel it, no problem. You don't mind, Hank, when we touch you? Yeah. What do you feel? Can you prescribe that a little bit? With the microphone? Maybe in the microphone. Kom eens even voelen, jongens. Dat is wel leuk. Kijk, die kans krijg je niet, joh. Kom maar eventjes. Ja?
It's really like the clicking, it's like rubbing against some bony structure. It's really, so if you want to try, it's really, you can really feel it.
Kom maar even, jongens. Eentje iemand. Kom maar eventjes voelen, maakt niet uit. Yeah. Oké. Mag wel, Henk. Okay, Hank allows us to do that. He says it's a strange feeling, but I don't feel pain when I do. He says the only thing is they have cold hands. All right. Okay, good. So that's what we feel. Huh? So kind of crispy, kind of. But it is not the whole range of motion. It's only a part of the range of motion. All right. Okay. Good. You guys asked me also, maybe we can also see, for example, if you put your elbows to the side and you go outwards here, yeah, as far as possible. Do we see a difference, left and right, guys? Nee, not a lot. Kan je weer even staan, Henk? En dan met je neus de andere kant op. Luister, Henk, ik ga je ook vragen dit te doen en dat te doen, oké? Dat weet je wel, hè? So actually, that was external rotation. Now we go for internal rotation. So maybe eerste niet aangedaan. Doe je. Yeah. Okay, so you see he's quite flexible. This is his uninjured side. Okay, you can go back. Now let's try the other side. How high can you go? It's quite high, huh? Still possible. Okay, good. Maybe you can have a seat. We can also perform some strength testing. We can use the microfat machine to do an accurate testing, but yeah, just because of time, let's do it a little bit more with my hand. So actually, I'm asking you, you keep your arm in this position, and I'm going to push. This is home of the plaque, home of the plaque, home of the plaque, home of the plaque. All right. I would say this is a 5 on the MRC scale. And we go here. It's also 4.5, 5. It's actually strength related. I wouldn't say a big difference in abduction strength. Okay. Now I can also do that for adduction. Okay, there we go. Dus trek hem maar naar je toe. Okay. There we go. Yes. We can do that for external rotation. Doe maar je elleboog blijft in je zij en je duwt je hand weg. External rotation. There you go. Okay. We do the other side. There you go. Same. And now you go internal rotation. Naar je buik toe. Binnen. Yeah. Quite good. And here. Quite good. Okay, guys. So actually, related to, let's say, range of motion assessment and strength testing, I would say left and right are about the same. How does it help us? The only thing we face now is crepitation. Estonia, help us out. Winging scapula, so you see kind of a winging scapula, that's true. Is it only one side or is it both sides? So that's the question always, huh? Good, guys. I will help you to speed it up a little bit, otherwise we don't have time for the musculoskeletal ultrasound, and I skip a few things already. But if I, for example, want to assess for an impingement, what kind of test do we do for that? Impingement test, do you know that? Hawkins-Kennedy, for example, can we do that? All right. Henk, eventjes blijven zitten. Wat ik ga doen is, ik ga heel eventjes je arm nemen. Ja, laat me los, laat me los, laat me los. Hoe is dit? Dat is deze kant. Ja, I saw a twitch. Was dat pijnlijk? He says, I feel a little bit of pain at the end range. Really, I had to push. There he felt something. Okay. If we think about, let's say, the rotator cuff muscles, what kind of specific test? For example, I heard supraspinatus somewhere. What kind of test for supraspinatus do we have? Yeah, okay, but a specific test for the supraspinatus. Empty can? Yeah, empty can test. Maybe you can stand up and you turn a little bit to me. All right, there we go. Yeah, and we push you down. You can hold up. Maybe now we turn a little bit. I will stand behind you a little that you can see it. I do it now here. No difference. I'm going to help you guys. If it would be a tear, what kind of test would be positive? If the supraspinatus would be ruptured, what kind of test would be positive? Yeah, the drop arm test. How? So maybe you can have a seat. Laten we weer met de gezonde arm beginnen. Henk, je weet wel, ik zet je hier. Jij houdt hem op, ik laat je ineens los en je houdt hem op de plek. Weet je nog? Ja. Laat maar eens even los. Ja. Okay. So this is right. Yeah. Okay, have a look, guys. Now we go here. I do it this side again. And I do this side again. Do we see difference? We see difference, huh? What kind of difference do we see? Also Estonia, what kind of difference did you see, guys? Maybe you can say, what did you see? Yeah, so actually the reaction time is delayed. Sometimes we think, okay, yeah, he really falls down the arm or something like that. That's never the case, almost. So now we have to think ourselves as a physiotherapist, and okay, I rush a little bit because of time, but still, is musculoskeletal ultrasound now an added value for this patient to get a proper diagnosis? What would you guys say? Is it good to look into the shoulder joint now a little bit? With the information that we gathered in this interview, there was a trauma, we felt crepitations, actually range of motion and strength is quite okay, but the drop arm test here is, and the impingement test at last is also not really negative, it's quite positive. So actually maybe musculoskeletal ultrasound can give us some extra information. That's the way I used in the practice. So let's go to the machine, and Marcel will turn on the big screen now also the what I see here on the ultrasound machine. So what we can do is that we put you a little bit backwards. Henk, kom maar, nog een beetje. Ja, zo is prima. Ja, perfecto. So what I'm going to do is I'm going to do first an ultrasound of the non-affected side. You always have to compare left and right. Links was aangedaan, dit is het. And I'm not going to follow the whole protocol. Single, yes, there we go. So actually I'm not going to follow the whole protocol. I'm going to ask Hank to start here because of time, and actually I can start with looking for the sulcus intertubicularis. I can move his arm a little bit like this, so I get more a dynamic view. of it. Now, and if we go here, yeah, okay. Let me see. Where do I get it? So here, okay. Okay, guys. So you see here a kind of a sulcus intertubicularis, and like Joost told you guys, you have to be careful that you don't get anisotropy. That means that you put a probe on the wrong side, or actually not with 90-degree angle, and then it's quite difficult to see the information. Now, if I go a little bit deeper, I see you see the two mice in the minor, and you see the fossa. The fossa you see, and in the fossa lies the tendon. If you would have an inflamed tendon, it would be way thicker, and also it would be more dark. So actually I did a sagittal view. I can also do a longitudinal view. So actually what I'm doing now is twist a little bit here the area, and yeah, I get a nice, let me see. Yeah, Joost is better in ultrasound than I am, but I'm trying. You get here kind of a view of a biceps. Okay, good. Now we go to the supraspinatus tendon. So maybe I can ask him, Hank, no, just like this is okay, Hank. So I ask him to turn his shoulder. What I'm going to do now is actually check his supraspinatus. You see the humeral head. Above the humeral head, you see tendon tissue, but you see that his humeral head has some chips. Yeah, so that is a little bit osteoarthrosis-like, but for the rest, his tendon looks quite good. Okay. If you guys have any questions, please don't hesitate to ask, but now I have to do it in dual side. Yes. Okay, wait till I have a nice picture. I have to do it left-handed. That's always a little bit a problem for me. Yes, there we go. Okay, so now I have a picture of the supraspinatus tendon on this side. Okay, there we go. Kunnen jullie het zien of niet? Of loopt hij niet? Huh? Okay. Maybe you can upload it here again, then we can get it on the big screen. So just put it refresh. Put the refresh button, please. Okay. Let's first again go to the biceps. Actually, you see you can make a nice dynamic view. We go to the tunnel. Let's see. Okay, I just go quickly to the other side, to the supraspinatus, because then we can compare. Okay, guys, and now have a look. Is it refreshing now? Okay, good. Yeah, we had no picture here on the big screen. Okay, there we go. So actually, I see here again the humerus head as I compare it. I see kind of a tendon-like structure. Is it 100% the same as on the other side, do you guys think, if I go like this? What would you say? Now I go a little bit more inward, and you see what happens? It totally disappears. So actually, this is an old, full rupture of the supraspinatus tendon. You can actually, there is no detection anymore. If you compare a little bit on the left side, I'm just going a little bit like this and like this. So you see here some black spots, but here on this side, contact is lost. There is no tendon connection anymore. So what we can see, I will show you later on an infraspinatus tendon, so that's better visible, but you see that the disconnection is there. And actually, after a while, after such a rupture, after a longer period of time, then you can see that this tendon who is ruptured distracts itself, yeah, and actually is kind of lost. I can maybe put two pictures together, then you can see it better. Let me see, let me make a nice part of it. Pop. If I freeze it, do you see a difference between left and right now? Ja, komt zo. Waiting for it. Do you see a difference between left and right? What is the difference, guys? Because actually it's about the same angle. You see on the left side, the healthy tissue, you see a nice lined tendon lying above the humerus head. And actually on the other side, you see some connection on the right side, but then all of a sudden it is lost, it's gone. And yeah, when it recently happened, when we first diagnosed this with Hank, then you could see still some connection between left and right, but on the long run, you see the connection is gone. Okay. So this can be the use of ultrasound imaging in your assessment. But your question is, of course, now, guys, I think, and I will ask the question to Hank as well, why we diagnosed it, there was a rupture, why didn't they do anything about it? Dus Hank, jij had een diagnose gesteld, and maybe you can translate, Christine. Christine, maybe you can translate, okay? Or you can forward it. We ask ourselves, okay, they diagnosed it, we hadden een diagnose gesteld. Waarom hebben ze er eigenlijk niks aan gedaan? Wat zei de dokter? What did the doctor say?
Daar ben ik niet geweest bij.
Ja, de huisarts toch?
Nee, bij de fysiotherapeut.
Oh, the physio. Oh, okay.
Ja.
So the physio decided, because actually he came back to his original physiotherapist with the pictures that we made. What did she decide?
Zij zei van tevoren wist ik het eigenlijk voor 99% zeker, nou is het voor 100% met
Okay. Okay. She said, in my clinical reasoning, I already knew it. En waarom heeft ze besloten om je niet naar de orthopeed te sturen voor een operatie? Weet je dat? Why did we decide?
Contact opgenomen met de huisarts, maar de kans is heel klein dat het helemaal goed komt.
Yeah. So actually, she was contacting the general practitioner, and the general practitioner said, "Yeah, in your age and with what you need to do, it's very hard. If it really recovers, it's a very long recovery." And the question is it worth the effort? So do you really get out of the operation better than before? Because actually, if you see his range of motion, would you have expected that with a full tear, guys? What would you say? No, Here they say no. And Estonia, would you have expected a full tear if you see how he's functioning, what he's doing? No. Some people think, yeah, but a full tear, then you cannot really lift your arm. But you know, you have a big deltoid muscle around, and he can take over. And strength loss, almost no strength loss. So actually you see that that is actually way better than we expected it to be. Why is it important not only making pictures, guys? What do you think? So why is it important not only making ultrasound pictures? Why do you really need to see the bigger picture of the patient? What do you think? So if he only would come, we make a picture and that's it. It's good to hear what his life is. How does he need his shoulder? What does he need to do? And is it worth all the effort to do something about it? By the way, there are many people who don't have a supraspinatus anymore tendon, and they are walking around, they don't know, and they can function very well. So it's always a decision on what to do with the information that we have. But like this, his physio told, actually I was already expecting it a little bit. The trauma, the twist, the snap, the pain, the age, maybe the age also of the patient. Now, older patients tend to have more likelihood to have this problem. I hear some, okay, still alive. So. Half 11, okay, good. So actually, we see this. Okay, how is Estonia thinking about it? Did they expect it, the supraspinatus to be ruptured?
They said yes.
Okay, yeah, good, good, good in diagnostic skills. So listening to my patient, and you see how we use musculoskeletal ultrasound as a more added value to what we do. In physiotherapy, I also use it sometimes to train with people. For example, if they have core stability problems, then you can put a nice ultrasound here on the belly muscles, and you can see the obliques and the transverse abdominis muscles. And if they need to train it, they get visual feedback, like a biofeedback tool. I think that's also very handy. In the Netherlands, it's also used a lot in pelvic physiotherapy, especially women who have problems there, and they can also visualize the muscles they train. So I think it's really an added value. And of course, we have the opportunity that we have the radiology department here and in Estonia as well. So I really warmly would recommend all the physios that they are trying a probe. Yeah, you're going to do that in the afternoon. In the beginning, it's quite difficult. You see, for me, it's also still practice and practice to do that. But it gives you added value in your information. And also for the patient, it's more clear, I guess. Want wat veranderde toen je dit wist, Henk?
Wat?
Ja, wat er veranderde toen wij dit hadden vastgesteld?
Ja, meer oefeningen met een elastiek.
Oké.
Dus van elleboog in je heup en dan kracht erop zetten.
Precies. So actually, after that, he says his treatment was more related to the problems that he had. So he was really training his rotator cuff muscles. He did a good job, I have to say, because internal external rotation is quite good. So really, you can compensate a lot. I think that's also what we can learn from this case. Yeah. Are there any questions here still? Maybe for Henk or for me? In Estonia? Okay. I think we can give a big applause to Henk for coming to us. Actually, Henk used to work here, but he's now retired. He especially came back for today. That's really nice that you did it. I wish you guys good luck. I'm actually envying a little bit Joost and Steven that I'm not around, because they told me where they were drinking a beer last evening, and I know the place, and I think, why am I not there? But still, maybe next year. But we see each other back. So this is the end for Eindhoven. I wish you guys a lot of fun in the afternoon, and still we have a look at Joost later on. Bye-bye.